fever of unknown origin, which is far and away my least favorite infectious disease consult
Oh no, I'm
clinic
sorry.
patient evaluation, but it's an important one because it can be interesting and it can be a quagmire. So starting off, I just wanted to talk a little bit about what exactly is a fever. Fever is technically defined as a core body temperature greater or equal to 38 degrees centigrade or 100.4 degrees Fahrenheit, assuming basal body temperature is 37 degrees centigrade. However, I think it's important to remember that it can vary if a patient has a different basal body temperature. This is particularly significant among the elderly who overall have impaired thermoregulation and lower basal body temperatures. Sometimes I know you'll hear a patient say, well, it's a fever for me. And I used to, write that off as not being significant, but it really can be, especially if you have an elderly patient. Hyperpyrexia is defined as a fever which exceeds 41.5 degrees centigrade or 106.7 degrees Fahrenheit. And this is often seen in the context of CNS etiology, such as stroke, hemorrhage, or trauma. So when you see fevers that are that high, I often think of causes outside of the infectious realm. In addition to CNS etiology, you might consider something like neuroleptic malignant syndrome as well, or even drug fever can sometimes have super elevated temperatures, but not so much infectious etiologies. And the other thing that is important and interesting to note about temperature is overall it has a diurnal variation. It's lowest about 2 hours before you wake up in the morning. So you can see here about 5 a.m. is when your body temperature is at its lowest. And I think this is important to remember. This is an ancient chart, but it's important to remember that because maybe a temperature that is not 100.4 but occurs at 5 a.m. may be significant. And it's overall highest in the morning, around 11 a.m. is kind of when we hit our peak, goes down a little bit throughout the day, up a little bit in the mid-afternoon, and then down as it gets later, and then is again at its lowest about 2 hours before you wake up, before it begins this whole cycle. The other interesting thing about body temperature is that depending on where you are taking the temperature, you can get different results. This was a meta-analysis from 1935 to 2017 looking at average body temperatures. Again, they noted that patients over 60 years of age had a lower body temperature, which on average was only about 0.23 degrees centigrade lower, but still significant. There was no significance based on gender. And they also found here, I put the numbers here, but there were definite differences based on where the temperature was taken, with rectal temperatures being the highest overall, followed by tympanic, oral, urine, and axillary. So again, if you think about that definition of fever here, assuming basal body temperature is 37 degrees centigrade, and you're taking an axillary temperature, which ranges between 35 to 36.9 degrees centigrade, a patient may have a real temperature with a fever reported as less than 38 degrees centigrade. I also wanted to say, please interrupt me at any time if anyone has questions about this. So today, though, after setting that basis about what exactly is a fever, we're going to talk about fever of unknown origin, and we're going to talk about it in a couple different contexts. There are different definitions for FUO in the community, in the hospital, among HIV patients, and then we're also going to segue a little bit into some familial fever syndromes, as well as conclude with fever in a return traveler. So the definition of FUO was first seen in this seminal 1961 paper that first described the occurrence of fever of unexplained origin. It was a case series of 100 patients, and a lot of their findings have actually held true today, although some have changed a little bit, which we'll talk about. And it is defined as a fever occurring over at least 3 weeks with a temperature greater than 38.3 at least once, and an unknown cause after a basic workup or 3 outpatient visits. In this original article, it was a week of hospitalization, but we don't really hospitalize people just for fever anymore. So this outpatient visit with no diagnosis has become more relevant. So this is an amalgamation of several different case series. They contain the original one, the Petersdorf case series, as well as one that was a little bit earlier, and then some more recent ones, as you can see, from 2005 to 2015. This one probably being the most relevant, not only because it's the most recent, but because they have 3,164 cases, and because diagnostic progress has really changed the way we evaluate FUOs. The point I really want to make here, though, is that infection, when there is a cause that's found, infection is usually the most common cause. Unclear what was going on in this Miller case series where 80% of cases were infectious. But in addition to infections being at the tip of your differential, a large proportion in most of the case series also had no diagnosis, which sometimes we do see with FUO. So this is another way to look at those cases, and they delineate based on number of cases which were caused by which thing. And I put the box around the infectious causes, and you can see the most common infectious causes in all of these case series were abdominal abscess, endocarditis, syphilis, and mycobacterial infections. And you can see that really is quite a bit. If you include TB, I'm not surprised that's found to be such a common cause for infectious FUO. However, and we'll talk more about this, but there's also a lot of inflammatory causes of fever that were also found in these case series. So over the last several decades, you can see that starting with red in the 1950s, blue in the 1970s, green in the 1980s, orange in the 1990s, and purple in the 2000s, that over time, we're actually a higher percentage of patients are found to not really have a diagnosis for their FUO. And that's really becoming the most common outcome for these patients. Whereas in the 1950s, infectious was overwhelmingly the most common cause that was found. So among community-acquired FUO, when there is a diagnosis, important caveat, when there is a diagnosis, 25 to 50% are infectious, 20 to 30% are attributed to malignancy, and 15 to 20% are attributed to inflammatory underlying conditions. This is just kind of a slide that has a lot of words on it, but when you look at infectious causes, the most common infectious causes are intra-abdominal abscesses, osteomyelitis, and tuberculosis, although literally any infection, you name it, can cause a fever, and they are things that have to be ruled out, but we'll talk more about exactly how to do that. Malignancy is also an important cause of fever, especially with leukemia, lymphoma, especially V symptoms can be very significant. And then certain fevers such as hepatocellular carcinoma or other liver malignancies are known to be important causes of fever, as is renal cell carcinoma. Although if you have underlying malignancy that's very advanced in a patient that keeps fevering, you can definitely, after ruling out everything, consider that. Inflammatory diseases, as we all know, can also be a cause of fever. Giant cell arteritis is one that we see a lot, IBD, lupus, Still's disease. And then there are non-infectious causes of fever that after doing your full infectious workup, you might also consider, such as central fever, again, in those cases of trauma or infarction or hemorrhage. Drug fever, of course, with that you can also look for eosinophilia, transaminase elevation, and take a good history about recent drugs that have been started. Factitious fever, this is one I think you always have to be a little bit cautious about attributing to somebody because you really want to make sure you've done a full workup before attributing the fever to that. Those familial fever syndromes, neuroleptic malignant syndrome, serotonin syndrome, pulmonary embolism, retroperitoneal hematoma, thyroiditis, clots in general. All of these things can also be causes of fever when you've ruled everything else out. So just wanted to start with a quick case. This is actually a real patient that I have. Would anybody like to read it? Okay, I'll read it. So this is a 45-year-old woman with no significant past medical history who reports intermittent fever for the last 2 years. She brought in a fever log to show, which does show fever greater than 101 at least once a week with frequent temperatures around 100.4 degrees centigrade. Or sorry, Fahrenheit. She denies any other localizing symptoms. She has a history of preeclampsia with birth of second child, malaria as a child, and schistosomiasis as a child, ascariasis and Entamoeba histolytica when she was traveling in South America. Regarding her social history, she's married, she has 2 kids. She works as an agricultural economist and she travels all the time. She was born in Zimbabwe and in the last 3 years has been to Gambia, South Africa, and Zimbabwe. She doesn't take any medications, not even supplements, nothing new started. Physical exam here, the point is it was really completely normal. She's a normal woman, no fever when we examined her, even though fever isn't listed here, blood pressure normal, heart rate normal, well appearing. We did a basic workup. We got a CBC, CMP, 3 blood cultures, ESR, CRP, HIV, UA. All of that was negative, but then CMV, IgG, and IgM was positive, EBV, IgG, and IgM was positive, and COVID IgG was positive. So we also got a CT scan, and it showed no pneumonia or pulmonary nodules, and it demonstrated no intra-abdominal abscess or signs of inflammation. So what do you think that the cause is? So we have a vote for a virus. So, you know, we get a lot of calls about CMV and EBV serologies. And one point I want to make here is that these IgG, IgM are really kind of non-specific. There's a certain proportion of people who, after having CMV and EBV, have positive IgM for months. Sometimes with CMV even a year later. So just having those doesn't really, in the absence of other kind of typical symptoms, tell us that a patient has a persistent viral infection. And she's had these symptoms for the last 2 years. So CMV and EBV aren't really things that we think about as causing 2 years of fevers or viral symptoms. I wanted to throw in COVID because I wanted to kind of put in a red herring there. You know, again, these fevers have been going on for 2 years, so before the diagnosis of COVID. So even though she had this COVID IgG, it really, it didn't seem that it could explain her fevers, although we are seeing more and more patients who describe themselves as these long haulers. So the right answer here was actually unknown. And the reason why I put this case is because often we can't really find a cause of FUO, but that's not always a bad thing. As we talked about, 25 to 50% of people with FUO remain without a diagnosis, and fever actually resolves spontaneously in about 80% of them. FUO has a very low morbidity and mortality of about 3%, and actually the longer the fevers have been going on, the less likely it is to be infectious, and also the more likely they are to have a positive outcome. So for these type of patients, it's not always very satisfying, but we provide a lot of reassurance and let them know, hey, I know we didn't exactly find out what it was, but we can tell you that it's nothing serious as far as an infection, and the fact that it's been going on for so long and we haven't found a cause actually means that it's probably not serious overall, and you're probably going to be okay, and it will probably get better. So in the healthcare setting, this is one that we get called a lot about in patients. This is defined as a fever greater than 38.3 degrees centigrade or 101, beginning after hospitalization. The patient has to be hospitalized for at least 24 hours, and this has to be existing for at least 3 days, and the fever begins again after hospitalization. So this isn't a patient that had a fever before hospitalization and then still has fevers during the hospital, of course. That's not a FUO in the healthcare setting. So common causes of nosocomial FUO: pneumonia, C. diff, pyelo, lines. viral infections, and this is one that we sometimes think about. If a patient had a NG or NT tube, then they're at risk for developing sinusitis. So if you've done a basic workup, getting an evaluation of the CT, or getting an evaluation with the CT of the sinuses can be considered. Of course, vascular causes such as thromboembolism, ischemia with MI or stroke, a bleed, an RP hematoma. Drug fever, this is a super common cause of FUO that we see. And then I wanted to highlight gout here because in part of the disease course of gout, it tends to flare after treatment for infection. So if you get a patient that has a new swollen joint, then, sorry, I just got a page. So if a patient has a new swollen joint after treatment for infection, then you would consider gout. Regarding FUO among patients with HIV, this can be seen in patients with a fever greater than 38.3 degrees centigrade, a little bit higher than for the general population, a fever occurring for more than 4 weeks in the outpatient setting, again, 3 days in the inpatient setting. Early on in the disease, we tend to see this just related to the HIV itself, but later on in the disease course, especially in the setting of AIDS, it's more commonly due to infection. Causes of FUO and AIDS include cytomegalovirus, Mycobacterium avium, pneumocystis carini, pneumonia, drug-induced FUO, Kaposi sarcoma, and lymphoma. And these are really kind of your late stage patients with CD4 counts less than 200 where you get worried about opportunistic infections. Fever and neutropenia with an ANC less than 500 is a recurrent fever greater than 3 days without establishing an underlying etiology. And neutropenia, similar to some of your immunocompromised HIV patients, you think of opportunistic bacterial infections, opportunistic fungal infections. Hepatosplenic candidiasis is an important one to remember. This is something that you can see in patients who had found neutropenia for a prolonged period of time and then start having a fever once their ANC recovers. Those patients, if you image them and see lesions in the liver or spleen, then definitely think of hepatosplenic candidiasis. And then aspergillosis can also be seen in your long-term neutropenic patients, and they can actually start developing fevers more as their ANC recovers and their immune system starts kicking in again. When you are evaluating an FUO, you want to take a really thorough history. You want to pin down the frequency of fever, duration of symptoms. Overall fever curve can sometimes be helpful too. You want to get their history of travel. The West and Midwest, you might think of endemic fungi. South America, Africa, Southeast Asia, a lot of these places have specific infections that you might think about. You want to know if they have any animals, any pets, any occupations. Sometimes people, we've had patients who say they don't have pets, but then it turns out they actually like breed exotic birds and they think of that as an occupation, not as a pet. So the way you ask questions is really important here too. Any history of living on a farm, being around farm animals. You want to know any food behaviors they have. Are they really into unpasteurized milk or cheese? Do they come from a culture where people eat raw meat or raw fish? You want to know if they're immunosuppressed and ascertain the degree of immunosuppression. You want to get a full list of their medications, including antibiotics. You also need to take a really good family history and ask if anybody else in the history has any history of fevers or have been worked up in the past for similar symptoms. And of course, you want to take a very thorough sexual history. Your initial workup should include, basic labs, CMP, CDC, ESR, CRP, LDH, TB test, HIV test. For the workup of FUO, actually, 3 routine blood cultures are recommended, taken from different sites at different times. Rheumatoid factors recommended CK, ANA, if your initial infectious workup is unrevealing. And some sources recommend checking serum protein electrophoresis as well. Imaging is a little bit hairy. I'm not exactly sure. I hope nobody ever tests you on this, because you can actually find different sources that recommend different things. So this really isn't a clear-cut answer on whether or not you should image and what the imaging should be. I think most providers would probably lean towards doing a chest, abdomen, pelvis CT, although I did find some papers that recommended doing a PET scan. The truth is, though, that when you look at studies about whether or not it's helpful, it's equivocal. Looking at chest radiographs, they're found to be helpful in one case series of 73 patients. They were helpful in 6 patients, but caused false positives in 8 patients. Regarding chest CTs, in a series performed in 46 patients, they were helpful in 9, but false positive in 8. Abdominal CTs performed in 60 patients were helpful in 12, but false positive in 17. And then PET scans, again, some sources really do recommend PET scans, although I can tell you they're not commonly what we do. In a case series of 70 patients, it was helpful in 23, so 33%, and there were false positives in 14%. Looking at all this data, it is true that out of all of the studies, it seems that the PET scan was actually maybe the most helpful when you just directly compare the percentages of what was helpful and what caused a false positive. But these patients can be frustrating because, as you see, you're almost as likely to find an answer as you are to find a false positive. So that's just part of the challenge of these patients. So it's complicated. I would say, again, our practice is to generally get a chest, abdomen, and pelvis CT after everything else is non-revealing. Some sources recommend a PET CT, and hopefully you'll never be tested on this. This is a diagnostic flow chart, and as you can see, this was actually from the American Association of Family Practice, the AAFP, and they actually also recommend a CT of the abdomen pelvis. But overall, as you see, it can be quite challenging and difficult to care for these patients. Another question, a 45-year-old woman is seen for follow-up, evaluation of daily fevers and fatigue of 1 month's duration. She reports measured temperatures as high as 38.3 degrees centigrade, but has no focal symptoms or weight loss. Medical history is unremarkable. She reports no travel or known infectious exposures. She takes no medications. On physical examination, temperature is 38.2 degrees centigrade. Blood pressure is 130/60, pulse rate is 90, BMI is 27. The patient appears well, and the remainder of the physical exam is normal and unchanged from a clinic visit 3 weeks prior. Additional negative testing includes negative HIV, PPD, beta-HCG, blood cultures again ×3, and a CT abdomen pelvis. So which is the appropriate next step? And the answer is actually a whole body CT. She already got the abdomen pelvis, so really they just meant a chest CT, but just wanted to reaffirm there that imaging can be used. And then after that, if the chest CT in addition to the abdomen pelvis CT is negative, then clinical observation would be the next step. Again, another question. 27-year-old accountant from New Orleans comes to the clinic for recurrent unexplained fevers of 10 years duration. His symptoms started at age 17. He had 3 to 4 episodes every year, and the episodes lasted for 6 to 10 days. Associated symptoms include muscle aches and sometimes red, painful eyes and abdominal pain. And sometimes his cervical lymph nodes will swell during an attack, but he never has a sore throat. When he was 18 years old, he had a negative laparotomy for suspected appendicitis. No one in his family has had any prior similar episodes. Fever and pain have always responded to short courses of antibiotics, and on one occasion, prednisone. A prolonged trial of colchicine has had no effect on his attacks, and he underwent an extensive workup, including blood cultures, chest, abdomen, pelvis CT scans, immunoglobulin, IgG, IgM, IgA, and IgD assays, and peripheral blood smears for malaria. All of these tests were negative. On exam, he was found to be febrile. He has conjunctivitis, a blotchy red maculopapular rash on the trunk, and tenderness to palpation of the muscles in his right leg. White blood cell count is 16,000 with a normal differential. CRP is 34, ESR is 110. Blood chemistries and chest x-ray are normal. So what do you guys think it is? It's clear, I think, from the setup that they ruled out all infectious etiologies. They even did full imaging. This is clearly a question that's trying to get you to consider some of these familial fever syndromes. So I'm going to open it up to you guys and give everybody a moment to think about it. Please let me know if you'd like me to scroll back so you can see the question again. Okay, so we've got an answer here. So Still's disease, anytime you get a question about Still's disease, I promise you there'll be something about ferritin being very, very elevated in an evanescent salmon-colored rash. I've never actually seen that rash, but that's what they always say. So I would say probably not Still's disease. Any other questions or attempts at an answer? All right, I will move along then. The right answer here is TNF receptor associated periodic fever. These are always really hard questions. This is directly from MixApp though. When you look at familial febrile syndromes, they're usually caused by mutations in inflammatory mediators or receptors. These are just some examples. Familial Mediterranean fever, which is autosomal recessive, hyper IgD, which is autosomal recessive. And then TNF receptor associated periodic syndrome, commonly acronymed as TRAPS. An important point here is you can ask for a family history, but as you see, these are autosomal recessive, and so they can occur in patients with absence of family history sometimes. Pediatric causes include periodic fever, adenopathy, pharyngitis, and aphthous ulcers, also known as PFAPA. Muckle-Wells syndrome, familial cold autoinflammatory syndrome, and later onset, you can sometimes see TRAPS, FMF, and hyper IgD. TRAPS is something that you consider. Sometimes question stems will give you some ancestry of the patient, so Irish, Scottish ancestry. Sometimes they'll also say that there was consanguinity within the family, and that can make you wonder about those autosomal recessive conditions. It's caused by a mutation in the TNF receptor. It has a median onset of 3 years, so in these patients looking for that history of that exploratory laparotomy for suspected appendicitis, that's when that kind of history can be useful. The range is very broad, from 2 to 53 years, so it's important to have this on your differential when you really aren't sure what's causing the fever, even in sometimes middle-aged or older patients. Symptoms include recurrent fever, abdominal pain, localized myalgias, muscle cramping, erythematous, tender rash, conjunctivitis, lymphadenopathy, or chest GU pain. It's hard because these things don't always occur together, but over time you can sometimes accumulate a constellation of these symptoms. Another way to try to differentiate these syndromes include looking at the time course of symptoms. That's why it can be helpful when you get those fever logs to try to plot out when the fevers occur. For TRAPS, symptoms generally increase over 1 to 3 days and then resolve, with the whole episode lasting about 5 days. And this syndrome tends to respond to TNF alpha blockers. Familial Mediterranean fever, this is probably the most tested of all of these familial fever syndromes. This is seen in people that sometimes say the Silk Road, Jewish, Turkish, Armenian, Arab genealogy. Symptoms include abdominal pain, chest pain, arthralgias, and rash. Rash is often more common in the lower extremity. In contrast to TRAPS, where symptoms last usually 5 days and worsen over 1 to 3, and FMF symptoms last about 2 days, and it tends to respond to colchicine. Hyper IgD is another syndrome that's seen with Northern European ancestry. It's caused by a mutation in mevalonate kinase. In this syndrome, you see an elevation of IgA and IgD, and it is periodic fever with abdominal pain and arthralgias. You don't have the other symptoms like in TRAPS. You sometimes see conjunctivitis and chest pain, GU pain. It's more generalized, whereas in hyper IgD, it's really just periodic fever with abdominal pain and arthralgias, which could make it difficult to differentiate from familial Mediterranean fever. But again, sometimes in this you have chest pain, where again, hyper IgD, just abdominal pain and arthralgias. Still's disease, which someone mentioned in the chat box, this is also very commonly tested. Again, look for keywords with that evanescent rash and then the markedly increased ferritin, and it is not associated with abdominal pain and myalgias. So here is another case, and this is another true patient. So this was a 25-year-old male with no significant past medical history, who presented with 3 days of worsening fever, chills, headache, and myalgias. He'd been to an urgent care center and a different ER and was tested for COVID-19 twice. And once he was found to be negative at both places, he was sent home. However, his symptoms persisted and worsened. He was from the DMV. He returned from Nigeria 4 days prior for his grandfather's funeral. He's engaged, lives with his fiance, has a pet cat, works as like a computer programmer, not on any medications, had a family history of leukemia, a mother with pulmonary embolism, and a father with diabetes. So what questions do you guys want to ask? Yeah, there we go. Somebody's thinking the right thing. So did he take malaria prophylaxis in Nigeria? Definitely a very good question to ask. Any other questions? That's all we're going to ask him. Does he have a cat, and did he take malaria prophylaxis? Okay, so I think M43, you guys are thinking along the lines of what we were thinking. This is a good case because when you have a patient who just came back from a tropical location, the things that you think about are different than those other patients. Now, this patient clearly doesn't qualify for our definition of FUO for either hospitalized patients or for outpatients, because this has not been occurring for several weeks. He's not actually even admitted to the hospital, but it's definitely a patient with fever. We don't know the cause. Very basic workup has come up negative. So definitely thinking about more tropical exposures is the right way to go here. So you want to ask exactly when did the fever begin? You know, did it begin while you were in Nigeria? Did it begin when you came home? How long after you came home? It's also important to ask when you have patients that traveled exactly where in the country they were. There's some places where there are different risks of infection in urban areas than rural areas, or in the same country, if you look at like a malaria map, there can be, even if the whole country says they have malaria, the actual map of prevalence can be more spotty. Animal exposure, definitely important. Were they around any farm animals? Were they in a rural setting? Were they in an urban setting? Malaria prophylaxis is also, as M43 correctly identified, a very important question to ask. Did you take malaria prophylaxis? And if so, what did you take and for how long? And depending on what you took, did you take it for the appropriate amount of time when you came back? And then another really important question is, have you lived in Nigeria or in X country for any period of time? Because people that live in a country can sometimes over time develop partial immunity to things that people who go back and visit years later who've never been there before don't have. It's often why we see people who have friends or relatives in these foreign countries who think that they're not at risk because their friends or relatives don't take malaria prophylaxis, can sometimes come in a lot sicker than someone who has built up that partial immunity from living in that country for any period of time. So on physical exam, he was febrile, temperature was 39.3, heart rate was 110. He was saturating well on room air. He looked tired, but not specifically uncomfortable. He had no anterior cervical lymphadenopathy, neck was supple, lungs were clear to auscultation bilaterally. He was tachycardic but had no murmur. Abdomen was non-tender to palpation, and he had no hepatosplenomegaly, and he had no rash. Labs demonstrated a white blood cell count of 10,000. Platelets were a little bit low at 91. Creatinine was a little bit up at 1.4, baseline of 1. AST was 76. ALT was 62, so mildly elevated. Billy was a little high too at 1.5. And then on UA, he had microscopic hematuria. So what do you think his diagnosis was? All right, yeah, so I think that BLES5, or yeah, BLES5, BLES3, M43, you guys are all thinking along the absolute right lines. This gentleman has malaria, one of the plasmodiums. Given the location and the severity of his presentation, it was D, Plasmodium falciparum, although usually it's, you know, you can try to figure it out based on like where a person went and what types of malaria are more endemic to that area, but also the sickest presentations are usually your Plasmodium falciparum, although every rule has its exceptions. So talking just for a moment about fever in a return traveler, which is what we'll conclude with, the main things to consider are malaria, dengue, mono, rickettsial infection, and typhoid or paratyphi, although the list of infections is much more extensive, but these are ones to definitely kind of have at the top of your internal list. In sub-Saharan Africa, malaria far outstrips any other causes of fever in returning traveler. In Southeast Asia, dengue at 18% is the most common, closely followed by diarrheal causes at 17%. And in the Caribbean, diarrheal causes are the most common at 15%, with respiratory at 13%. And then when you are talking to a patient who is returning from travel, you really want to pin down the symptoms, but also the timeline of symptoms, as this can be a very important clue to what the cause could be. If a patient presents with fever about less than 14 days from travel, you could think about Bartonellosis, again, though that's really 1 to 3 weeks, but on average less than 14 days. Dengue, generally within 4 to 8 days from exposure. Coccidiomycosis, 1 to 3 weeks. Diphtheria, 2 to 5 days. Ehrlichiosis, 7 to 10 days. West Nile, 2 to 14 days. Enteric fever, 7 to 18 days. And chikungunya, 2 to 4 days. And the importance of trying to think about this is, let's say this guy came in, you know, malaria is a tricky one, which we'll talk about, but knowing the duration can definitely help narrow your differential. Continuing this list is histoplasmosis at 10 to 14 days, HIV, this really 1 to 6 weeks, so that's very broad, but acute HIV, definitely fever within the first couple weeks. Influenza, 1 to 14 days, Lassa virus, 7 to 10 days, Legionella, 5 to 6 days, leptospirosis, 7 to 12 days, Lyme, erythema migrans within 7 to 12 days. Malaria falciparum is generally 10 to 12 days, and Vivax, generally 14 days, but I want to caution you on malaria because there's definitely cases of it being, especially with Vivax and Oval, which have a latent form in the liver, reactivating in months and in some cases even years. So malaria definitely is a good thing to consider if a person has a travel history that's not quite in that, you know, 10 to 14 days approximate period. Measles, 10 to 14 days, yellow fever, 1 to 6 days, and Zika, 5 to 6 days. 14 days to 6 weeks, you can sometimes see amoebic liver abscess, hepatitis A, and about generally 28 days on average, hepatitis C, 6 to 9 weeks, hepatitis E, 6 weeks, leishmaniasis in 2 to 6 months, and schisto has a long period, 14 to 84 days. Even longer, you can consider fascioliasis, 6 to 12 weeks, hepatitis B, 90 days from exposure, and TB, of course, 4 weeks to years, and then malaria, rare cases up to 3 months. Just to kind of hammer home the point, malaria is one of those diagnoses that you really can't miss, because the longer that you delay the diagnosis, the more fatal the outcome can be. So malaria endemic regions include the Eastern Hemisphere, involving most of Africa, as well as China, Pakistan, India, Indonesia. In the Western Hemisphere, many places in South America, Central America. We don't really think of it so much in Mexico, but again, this is just a general map. You would really have to kind of hammer in specific locations. It's important to remember when you're talking to travelers that infections can be acquired in layovers. Fevers related to tropical exposure can begin during travel or on return, and that's why that time course is so important. Malaria is possible even if a smear is negative, so definitely get more than one. Acute malaria can have a normal physical exam, kind of like our gentleman. He just looked tired, but he definitely was malaria positive on smear. Risk may differ, as we discussed, between residents of a country and travelers of a country, and risk can vary depending on season or year. So knowing what time they traveled and what the season of the country they came from is also very important. And also be on the lookout for common causes at unusual times. I think that the typical patient is one who's maybe traveling in South America in the summer who comes back with the flu. You know, who expects the flu in July? But that can definitely happen with people depending on where they're traveling. If they're in South America when the flu is having an outbreak, then they come back. So knowing where they traveled when and what seasons it is in the place they're coming from is very important. And just kind of to end with some common buzzwords based on history. If there is in a question stem incarceration, travel to India, or homelessness, think tuberculosis. If there's history of IV drug use and a new murmur, think endocarditis. Homelessness, fever of unknown origin, think Q fever. Eating unpasteurized cheeses, think brucellosis. Travel to West Africa, think malaria. Caught a stray cat, basically anything. Malar rash, joint pain, think lupus. Salmon colored rash, pharyngitis, that evanescent rash, high ferritin, think Still's disease. And large lymph nodes, weight loss, night sweats, think B symptoms, and think lymphoma. So that is everything. I'm happy to take some questions if there are any.